your benefit, we'll let you know that you are surrounded by students, teachers, parents from a spread across the country, so as far as Donegal and Tipperary, so really welcome to you. My name is Alison Enright, and I'm Director of what we call the Scope Health and Social Care Professionals here in St. James' for the Therapy Services. And we use SCOPE as an acronym actually for the 5 disciplines that are organised in our group of services. And we're going to hear from them all today. So they are speech and language therapy, social work, clinical nutrition, occupational therapy, and physiotherapy. So maybe just to set the scene a little bit about St. James's, where you are today, you're on campus with our Trinity partners. And St. James's is the largest academic hospital in the country. We have 1,000 plus, about 1,080 inpatient beds open at the moment. And we treat patients locally in our catchment area. But of course, we have a significant number of regional and national specialties. Patients who need much more specialist intervention, for example, cancer care, would come to our services here and they would discharge them back locally, and the more acute part of their intervention has been taken care of. And St. James's is also very proud of its focus on research, and we genuinely believe that if we're not researching, we're not thinking, we're not making things better for the future of healthcare. So we are an academic health sciences centre in partnership with Trinity as well. So coming back to the SCOPE Directorate, we are effectively a group of about 300 people, 8% of the clinical workforce here in St. James's. And we do operate as one large group, so we're 5 different specialties, but we provide care on every pathway in the hospital, so they could be inpatient pathways, outpatient pathways, and our huge focus is to try to improve how we're integrating our services, and I hope that'll come across today, and I'm sure it will from the presentations that you're going to hear. And so that is something that we're consciously improving, and to make that a little bit real, some of you may know somebody who's had a stroke, for example. And if somebody comes to us and has had a stroke, they will need all of our services, but they need all of our services working really closely together, wrapping care around the patient so that we understand the needs, that we are coordinating the care really tightly with the patient and the family, and then onwards maybe to community services when they go home. So a huge piece of our work is working together. And to equip us as 5 different disciplines, we are different. Each of the specialties, as you'll hear, have a different training focus, but we do share an awful lot in common. We share a lot of clinical skills and knowledge in common. We also share research skills, key to what we do to improve the way we treat patients. We share quality improvement science, so a big part of our work is applying quality improvement science to improve how we treat patients. And so that's a methodology that we share across our services as well. And I would say most of all, our 5 disciplines share a genuine interest in people, in patients, and in supporting and enabling our patients to be the best version of themselves and their overall well-being. So today we are going to invite shortly representatives from the 5 different disciplines. We're going to break the session into 3 presentations, then we'll have a break, and then you'll hear the final 2 presentations. And what we'd love you to do is to be vocal in your questions. We want to hear from you. We want the content to be really relevant to what's on your mind, because we're conscious you're using this as an opportunity to make some decisions at an important stage in your own lives. So find us at the break time, and if you, for example, if you want to speak specifically to a dietitian, ask us where can you find a dietitian, because we have lots of representatives in the room and they're here to be able to answer your questions. So don't be shy. This is a couple of hours that's really important for you, and we want it to be. Couple of things in terms of housekeeping before we kick off. The food, most importantly, will be served next door. There's a room to our left. I have a son who's just a little bit younger than you, and I asked him what would be important for you to hear today. And he said, well, are they going to get a break and refreshments? So it's all that was on his mind. So let's answer that straight away. You will. We'll have 3 presentations, then you'll move into the room next door, have a break and come back. The bathrooms are to the left if you go out the door, and in the event of an emergency, which of course is most unlikely, there are 2 emergency exits. The left outside the door at the end of the corridor and nearer to the right here, but obviously we'll be directing you should anything arise. And finally, what we would love from you is some feedback. So we'll have a QR code later in the session, and we'd really invite you to share with us what has worked well and what you want to see us do a little bit differently or do more of, so that we can ensure that the event for your future transition year students is as relevant as it can be. So I'll hand over at this point to John from Physio, who's going to kick us off. Before I do, I am going to just say that I was in your shoes many years ago, and I trained as an occupational therapist, and my own background began there. And I can honestly say that it was a terrific decision in terms of a career choice. It's extremely rewarding to be part of patient journeys, to be trusted to be part of that journey, and to work as teams to really make the experience for those we serve as effective as it can be. So you'll know what's right for you, but I'll depart, I suppose, with that word of how rewarding and how proud, I suppose, we feel here for what we're entrusted to do for those we serve. Okay, so over to John, please. Thanks, John.
Great. Thanks a million. Hello, good afternoon. You're very welcome to St James's Hospital, as Alison said. My name is John, and I'm one of the many physios here in St James's Hospital. One thing that we're here to talk about today is what each of our professions do. And one of the main questions that we get asked and we get assumed of as physiotherapists is kind of a perception versus reality, sort of a scope on things. So when I generally ask anyone what a physiotherapist is, commonly these are the 3 answers that I get, okay? There are people who work with sports injuries, such as ACLs and dislocated shoulders. There are people who give massages and more massages and sports massages. And they're the people who run onto the pitch, so the men and women who run onto the pitch during a game when an injury occurs. And the bottom line is that, yes, that is all correct, but there are so many more things that physiotherapists offer to people all around the world. So I guess in general perspectives, the general role of a physiotherapist is to help people to get back on their feet. We work closely with patients to help reduce their pain. We have a big goal in terms of helping to improve a patient's or a person's movement and strength. And I guess putting all these 3 things together, the main goal of a physiotherapist is to improve a person's overall quality of life. Okay, that can be pitch side, that can be in the hospital, that can be in private clinics, that can be with children. But the overall goal of a physiotherapist generally is to improve a person's overall quality of life. And I guess I'm here today in the hospital, which is what I'm going to talk mostly about, but there's so many different types of places and different areas that physiotherapists can work in, okay? So physiotherapists can work in private practice clinics, they can work in the community, so on the roads, going into people's homes, obviously with sports teams, in any vast variety of sports, and also in paediatrics, so with children as well. Is a common place for physiotherapists to work. But basically what I'm here today to talk about is what physiotherapists do and what they offer in the hospital, okay? So the type of patient a physio might see in the hospital, okay? There are so many different amounts. So I was obviously working this morning, and even from 8 o'clock to 12 o'clock this morning, the variety of patients that I've seen actually shocked me this morning, never mind shocking anybody else. So basically, these are sort of the main groups of patients that you might see in St James's Hospital or indeed in any other hospitals around the country. So after surgery, so your hips, hip replacements, knee surgeries, shoulder surgeries, so rotator cuff surgeries. Basically, we see so many patients post-surgery. And the main role of a physiotherapist when you're dealing with a patient post-surgery is to help the patient to get out of bed and moving again, okay? If needed, that might mean giving the patient an appropriate walking aid, like a walking stick, like a Zimmer frame, like a four-wheel walker, any different sort of an aid that might help the patient walk again or walk more safely, and then obviously to teach them how to use it safely and correctly. One of the big areas of physiotherapy that people often don't realise that we do is working with patients with breathing problems and patients with lung conditions, okay? In a general scope or a general theme, basically if patients are in bed for too long, if they're not moving enough, their lungs start to sort of build up with phlegm, with mucus, and basically we work hand in hand with the patient to help get them moving again, giving them breathing exercises, different sort of positions that will help clear their lungs from phlegm and from mucus and help them to breathe a little bit better. Also like that, we work with patients to improve their endurance, so in walking, which might be limited by poor breathing techniques, but it's often a part of physiotherapy that often gets disregarded or forgotten about. But it's one of the big things that we do here in the hospital. Thirdly then, stroke and neurological patients. So as Alison said, many of us here will know a patient who has had a stroke, or a person who has had a stroke, should I say? Sorry, I'm so used to saying patient. But as a physiotherapist, we work with a person who has had a stroke to regain specific movements that they might have lost. So we work with them to improve maybe their balance, which will reduce their risk of falling. We work with them to get certain arm movements back, get strength in their specific arms and legs. But one of the common things that we do here in the hospital is, and see in the hospital, is stroke patients. And then probably the most common that we see here in the hospital is patients with falls and sort of the older adult population. So as a physiotherapist, again, our role in this scenario would be to help an older person to build their strength in both their upper and lower limbs, to work on their balance, and also building confidence is a big thing with people that we see in the hospital. Being in hospital can knock your confidence. People are fearful of moving, people are fearful of walking again, because of certain things that they have going on with their conditions. So ultimately it's our job to try and help build their confidence, build their strength, and ultimately trying to reduce their risk of future falls and get them moving again. In doing days like these, one of the big questions that younger students and younger adults often ask is, what do you love most about your job? And there's many things, but these are some of the things that I would say from a personal perspective love most about my job. So the work-life balance is a big thing. So I spoke previously about all the different variety of physiotherapy work that you can do, and I guess each individual has their own choice on how much physiotherapy sort of areas they can go into. So you can do a little bit of pitch side work, working here in the hospital, working in pediatrics, but also getting to see different parts of the world as well. So there's a good work-life balance involved in physiotherapy. There's so much variety, as I said, and different areas to choose from. And where there's different areas to choose from, that means there's exciting job opportunities worldwide. So in the four corners of the globe, there's physiotherapists needed somewhere. So that really gives us great opportunity to expand our field and work worldwide. Again, in sort of similar vein, there's great career progression potential from staff physiotherapists all the way up to clinical specialists and working into different areas and different fields. But as Alison said earlier, one of the main things I actually enjoy most about my job is working as part of a wider multidisciplinary team, okay? Working with the guys here beside me who are going to talk to you a little bit later on. We all do different jobs with people, we all have different roles with patients, but ultimately we do all have the same goal, and that is to get a person better and improve their quality of life. And I guess when we're working together with the same goal, it makes that work a little bit more enjoyable. Seeing a patient or a person progress from being quite unwell as they enter the hospital or as they come in as an outpatient with a broken arm or maybe a sprained ankle, to getting them back on their feet again, to be able to say that we've achieved something together is obviously very valuable. But I guess the most beneficial and thing I love most about my job is that I know that I'm making a valuable difference in a person's life. And often patients will feed back to us saying the difference that we make with them is more than they will ever know, more than we will ever know, should I say. And I guess that's probably the most rewarding thing I do love about my job. Okay, back to school, back to you guys. One question we get asked an awful lot as well, are there any subjects that would be beneficial if I wanted to be a physiotherapist? Yes, and yes is the answer. But the big recommendation I would give is to check the entry requirements for a specific course of your choice. And I'll talk a little bit later about what that means. But commonly, when doing a physiotherapy course, whether that's an undergraduate course or a master's course, they'll commonly ask for one of the three main sciences covered at Leaving Cert level, which is biology, chemistry and physics. And then sometimes what can be beneficial but not essential is PE. Myself, I did both biology and chemistry, but I guess I did find biology had the most sort of crossover between Leaving Cert and into studying in university with relevance to physiotherapy itself. And then how do you become a physiotherapist? Probably the biggest question that we do get. So there's many ways of becoming a physiotherapist, okay? And that's something I really need to highlight today. The most common and probably well-known way of becoming a physiotherapist is by doing your Leaving Certs, applying for CAO, getting the points, and doing an undergraduate physiotherapy course in one of the colleges or universities named up on the left-hand side, so Trinity, UCD, RCSI, University of Limerick, and the new one then is in ATU up in Letterkenny. So that's a common way, but I can't specify enough that there's so many other ways of becoming a physiotherapist. In Ireland, the most common route, if not going the undergraduate route, is by doing a master's. Okay, so first, generally, a lot of the people that I work with and know in different parts of the country would have completed a science-related undergraduate course. That might be sports science, it might be sports therapy. I know that they do in DCU. They have a sports science and therapy course that they do in Athlone. But doing some sort of a science-related course, then generally they'll have an interview with one of the one of the colleges up here on the right-hand side to enter into the master's program, which is generally a 2-year program, which at the end of both the 2 years of the master's and the 4 years of the undergraduate physiotherapy course, people can qualify to work as a physiotherapist here in Ireland. But as I said, and as Alison said earlier on, if you want to sort of ask me a little bit more specific about any of these, catch me at the lunch, and I'll be happy to answer any of them questions. But again, I'm going to specify it again. If you do not get enough points for, say, the undergraduate course, there are so many other ways of becoming a physiotherapist here in Ireland and abroad. I guess bringing it back to me then, so my own physiotherapy experience, I went to University of Limerick, which is a 4-year course, and you can see the sort of our group here on the right-hand side. What the 4-year course kind of layout looked like, and it's kind of similar in all different masters or in undergraduate courses in Ireland, but maybe a little bit of variation depending on the college that we're in. But first year looked primarily like at background learning, so at our anatomy, at our foundation work of the human body. The second year then was kind of definitely progressing into lots more of hands-on practical work and people skills. One of the things that people often forget about. We deal with people day in, day out. So second year put a lot of focus on working with people. Third year then was when we started to go out into the big bad world. So we got our first couple of placements under our belts. I myself went to Galway University Hospital and Portiuncula University Hospital. And then back in college, when we weren't on placement, we were working on sort of our finer physiotherapy skills, like working with stroke patients, working with patients with respiratory conditions. And then in fourth year, we had our thesis submission, so our final year project, then getting our last bit of final couple of placements out in different hospitals and different regions before graduation. Okay, so that's kind of what I hope we'll cover the general scope of physiotherapy here in the hospital. One thing we got feedback from last year was being able to talk through maybe a patient, okay? So what we're going to do here today is we're going to meet Mary, okay? And I want you guys to imagine that Mary is a patient who has presented here to St. James's Hospital. And we'll say that Mary presented here last week, and each of us have a role in getting Mary discharged from hospital and home in the safest and best way possible, okay? So Mary is a 72-year-old woman who lives alone. She was admitted to St. James's Hospital after having a fall at home. And on admission, so when Mary presented into hospital, she was diagnosed with a hip fracture from having her fall. And I'm going to see her day one post-surgery. She was moderately malnourished. She has presented with some swallowing difficulties from a recent stroke she had in the last year. And other important factors to know about Mary is that she lives alone and has actually limited family support around her. She's struggling with her mobility and her confidence, and she has kind of low mood since being admitted to hospital, as anybody would. So I guess from a physiotherapy point of view, I'm seeing that Mary has come into the hospital, and I have to identify from her case what am I going to do to help get her home. So I guess the three things that we can identify from Mary's presenting condition is Mary has a hip fracture. So that's obviously a highlight point of Mary's presenting complaint that I'm going to have a look at. I have highlighted swallowing difficulties, but I guess not so much the swallowing difficulties, but just to be aware that Mary has had a recent stroke, so there may be a little bit of a knock-on effect on her mobility as a result of that. And another thing then is that Mary, in general, is struggling with her mobility and her confidence when she is walking. So I guess these are the three physiotherapy targets that I'm going to look at when Mary comes into the hospital. And what I'm going to do, what's my role when dealing with Mary? So first and foremost, I want to make sure that I'm going to help Mary to move safely in the immediate days after surgery. So Mary is after having surgery on her hip. So it's so important that after having surgery on her hip that Mary gets up and gets moving again, okay? Often people think that, okay, because she's had surgery, she's going to need to spend a good few days in bed to relax. And that is the case in I suppose, in some ways, but it's really important that Mary gets up and gets moving again so that she doesn't lose her strength and lose her movement from having the surgery. So after a few days of maybe getting Mary to the edge of the bed and maybe making sure that she's sitting out into a chair, I'm going to start doing some exercises with Mary to make sure that we're starting to improve back her strength and her balance, which is likely to have taken a hit from spending so much time in sitting and in the bed after having surgery. Being mindful that Mary has had a recent stroke, it might be a case of having to introduce a walking aid, so something like a rollator Zimmer frame with Mary. Something that'll help to build her confidence when she's walking, so that might help her to and encourage her to do it on her own. Because Mary has had a surgery and because she's spending a few days in hospital, it's very important that I'm doing some breathing exercises with Mary to make sure that her lungs are clear, to make sure that she's breathing correctly, and to prevent complications such as developing a chest infection in hospital, developing a pneumonia, etc., etc. And lastly then, and I'll revert back to what Alison said at the start, our ultimate goal is to make sure that Mary gets home safe. So I'm going to make sure that I'm working with the OT, with the dietitian, with the speech and language therapist, with social work, to make sure that we're all coming together at the same time, at the same place, to make sure that when Mary is being discharged, that it's in the safest and the best way she possibly can be. And I guess that's me. So thank you for listening to me blab on a little bit. And I know you're going to listen to the rest of the guys here now, but I want to wish you the best of luck in whatever you do decide to do. There's people my age who still don't know what they're doing. There's people older than me who still don't know what they're doing. So everyone will find something that they'd enjoy doing. So I wish you the best of luck in deciding that, okay? Thank you.
Hello, can you hear me? Okay, so my name is Alice and this is Connell, and we're here to speak a bit about occupational therapy. So what does an occupational therapist do? So the definition for occupational therapy, so it promotes health and well-being by supporting participation in meaningful occupations that people want, need or are expected to do. So the primary goals of an OT are to support independence, health and well-being and quality of life. So you might ask, what are these meaningful occupations that I mentioned? So I suppose when you think about meaningful occupations, think about what are the things that make us us. So what are your own important roles and routines in your life, your activities that make up your daily life, and these activities that are kind of purposeful and meaningful to you. And these can really change across the lifespan. So I suppose for you here today, you're all students. that's an important role in your life. Attending school, doing your homework, and I'm also sure you all have extra kind of curricular activities to do after school, so sports, art, anything like that, and these are important activities in your life. And this can change across the lifespan. So for us, we're meeting, people who are here in hospital. I work with kind of the older population. They also, have important roles and activities in their life, but sometimes an important and purposeful thing for them is just being able to live at home as independently as possible, being able to engage in just their activities in everyday living. And that just shows, I suppose, how much they can change across the lifespan from students to the older population that we're meeting. So who do we work with? So as I mentioned, I work with the older population mainly, but I suppose depending on the area that you are in, you can work with as young as premature babies, you can work with kids, adolescents, all the way up through adulthood and the older population. So where do occupational therapists work? So we work in acute hospital settings. So that's like here at St. James's, and there's many acute hospitals around the country. So you might be aware of Cork University Hospital, Galway, and in other towns and cities across Ireland. We also work in primary care or in the community. So when we're in the community, we're often working with people in their own homes and meeting them in their own environments. We also work in paediatrics. And so again, we could be working in the community, meeting people in their own homes, or as well going out to schools and assessing children in school. We also work very much in mental health settings across the country. So that again can be in acute hospitals that are specific to mental health, or again going out to people in their homes, or maybe in kind of supported living situations as well. And we also work in rehabilitation settings. So many of you might be aware of the National Rehab Hospital that's based out in Dunleary, and then also I suppose in our own work and across the board in all of the settings I've mentioned, and especially here in St. James's, we have a strong kind of rehabilitation and recovery ethos, and we try and bring that into our work with all of our patients here, progressing them back to being as independent as possible and regaining skills. So those are kind of some of the areas that you might find us working in. We just wanted to give an overview of kind of a day-to-day of an occupational therapist. So it's quite varied, it's quite broad. One of the things you'll find us doing every day, functional assessments. This can be as simple as when you're meeting your patient, you might do an initial assessment, finding out about their kind of home environment, social environment, and then a functional assessment. So seeing if they can get in and out of bed, if they can dress themselves, shower themselves, make themselves meals. And it's just those kind of simple activities of daily living that you're assessing for. You might find that your patient is having difficulty in certain areas that you've assessed, and then you're looking at that rehabilitation and recovery. You're seeing how you can progress them back to being as independent as possible in whatever area they're having difficulty, as safe as possible, and just getting them back to being as independent as possible. And that can often involve goal setting. So we'd work a lot with our patients around setting goals, what it is that they want to improve on, what they want to work on, and we'd make sure that they'd be the ones telling us what their goals are, and just always making sure that you're working on specifically what's actually important to the person. Then cognitive assessment and rehabilitation, that's a huge part of our work. So cognition kind of looks at your memory, someone's thinking, their judgment, and often you might meet patients here who have kind of some issues or are struggling in that area. So you're identifying where the issues might be, supports that you can put in place, maybe some rehab as well, and just how you can get them to live as safely as possible and independently with these deficits they might have. We're also very involved in hand therapy assessment and intervention. There's a lot of opportunity here for training and development in James's, such a big hospital. There's always projects that you can be getting involved with, different courses you can get involved with, also people going on to kind of onward study as well in particular areas they're interested in. As previously mentioned by John as well, interdisciplinary working is a huge part of our day-to-day life. So every day you'll find yourself, working with physios, speech and language therapists, everyone in that MDT, and I suppose you're, doing one-to-one sessions or group sessions, and you're really kind of bouncing off each other, and they're coming with their expertise and you're coming with yours, and you're all with that one focus of kind of patient care and client-centered care. And then also seating and equipment is a huge part of our day-to-day. So in those functional assessments and in that rehab and recovery process, you might identify that someone actually needs kind of particular equipment that would help them to be able to engage in their daily activities and make them more independent. So you might be kind of finding out what that equipment is and making sure they have that, or else seating as well. So somebody might need specialised seating, so you're kind of doing your seating assessment and making sure you get them whatever wheelchair or seating that they might need. So that's just some of our day-to-day roles, and I'll just pass you over to Connell here.
Yeah, thanks, Alice. So just to talk a little bit about kind of the skills associated with being an occupational therapist. So firstly, we have kind of our clinical and assessment skills. That's kind of, as Alice mentioned, how we assess a person when they first come to us, from kind of a physical, a cognitive and an environmental perspective in order to make kind of a treatment plan for that person. Then we have our rehabilitation and therapy techniques. So I suppose one of our main skills is being able to incorporate activities and tasks and how we adapt those tasks to meet our patients. And then problem solving and adapting. I suppose no two patients we see are the same. We have to be able to creatively think and adapt based on what that person is presenting to us with. Our communication and interpersonal skills. Every day we talk with patients, families, our other healthcare professionals, and it's really important we have clear communication, so I suppose everyone's on the same wavelength and we all know what's going on. With regards to education and coaching, as therapists we're constantly upskilling to ensure we're meeting the highest standards for our patients, but also we're also educating our patients, I suppose, how we can adapt the task to make it easier for them, or how they can be more independent in that task. And then if we have kind of students coming into our department as well, there's another element of education and coaching, I suppose, preparing them with the skills needed for future work. And then finally, our organisational and professional skills. That's just things like our time management, our caseload management, all those things that make sure we're kind of upholding our professional standards. I suppose it's important to note that all of these skills, you might not have them right now. I certainly still don't have all of them, and it's an ongoing work, but they're kind of developed as you as you're going through your college time, and then as you're going on into your working life. So then just to talk a little bit about kind of how you're able to get into OT. So these are our level 8 undergraduate courses available in the Republic of Ireland. So as you can see, we have University College Cork, University of Galway, Trinity College Dublin and University of Limerick. So last year the courses would range from about 540 points to 566 points. All of the courses have built-in placements. So there's 1,000 hours of clinical placement you have to complete 3 or 4 years, and that gives you an opportunity to apply all the knowledge you're learning in college into a real-world setting. Obviously, it's important to note that there's loads of other routes into OT. It's not just those level 8 courses. So, and as John already talked about, the postgraduate or master's route. So for OT in Ireland, there's a master's course in the University of Limerick. So generally, you'll have completed another undergraduate course, and then you'll apply into the master's. There's also loads of opportunities in the UK, in Northern Ireland, and in England, Scotland, and Wales. And you apply through the UCAS for that. So that's very similar to the CEO we have here in Ireland. You just apply with your Leaving Cert results. We also have the mature student pathway, which is maybe for people who might be returning to college later in life, or might be going to college for the first time. The universities generally consider kind of things like past life experience, past working experience, and there's generally an interview for that process as well. And then there is also alternative courses. You might do kind of a 4-year course and go on, or some access programs. It's important to note with all of these, there has to be a link into somewhere that will offer placement opportunities. The placements are the important thing to be noting. So then just to touch on what I enjoy about my job, so being involved in promoting independence, I suppose we have a unique opportunity here in the hospital to be involved in a patient's rehabilitation journey, being involved in their recovery journey, and it's a real privilege to see them come along in that journey. Our clinical skills and learning, so as I said, we're ongoing, always getting the opportunity to upskill to learn new things, to enhance our patient care. As was already mentioned, and I'd say would have been mentioned by every profession, our teamwork with the other healthcare professionals. It's great when we come in the morning, we often have a meeting with all the other healthcare professionals just to make sure we're all on the same wavelength about the patient, and then we often see patients with the other professions as well. And I enjoy the fact that our job is very creative. Every day is different. Every patient is different in the way you might have to adapt and think and find solutions to what they're presenting to you with. So then just to touch on the case study, as mentioned already, Mary is a 72-year-old lady who presented to St James's here with a hip fracture. And so from an occupational therapy perspective, I suppose the first thing we would do is our initial assessment. So we would meet Mary and we would get kind of a social history, what's going on at home, who lives with her at home, and what's currently in place, and then getting a picture of her home environment. So what sort of things are in place to help her at home. And then her baseline function, what she would have been doing before she came into hospital, and her current function now, and comparing those two things to see kind of what our treatment plan will have to be going forward. And then next we'll have our rehabilitation. So we will kind of do a lot of things in our rehabilitation. That'll include kind of our transfer practice, so maybe getting in and out of bed, getting in on and off the chair, on and off the toilet, things like that. And then practicing dressing, practicing washing, and practicing mobility as well. And any other things that are important to Mary. So Mary might enjoy, cooking a meal at home. Can we bring her down to our OT kitchen and help her try and do that again? So then often we might make a recommendation with our social worker colleagues to apply for carers at home to support kind of personal care ongoing, so that when Mary goes home, she might have someone coming into her to help her with those things if she's still needing help when she goes home. And then some of the things we might do is we might provide equipment from the hospital. So the picture here you can see on the right-hand side is called a bed lever. So that's something that can help a person be able to get in and out of bed safely and independently without needing kind of someone to help her. She can just hold on to that and swing her legs out of bed. And then because Mary's had a fall, we'll be providing falls education, kind of teaching Mary things she can do to prevent future risk of falls. And we might provide her with pendant alarm information. So that's the picture you can see there, with the person wearing the thing that kind of looks like a wrist around a watch around the wrist. So basically that is, if someone was to have a fall at home and they're on their own, they could press this button to access help in the case of an emergency, I suppose. We've had a lot of patient feedback who say, actually, I never had a fall after I put it on, but it gave me so much confidence that if something was to happen, that someone would be there to call. And then the final thing we do is kind of to make sure, I suppose, Mary wasn't left when she just left the hospital. We'd make a community OT referral to our colleagues in the community to assess Mary's home environment in terms of future planning. So is there anything they can put on her stairs, maybe a second handrail or a stair lift or things like that, anything in her bathroom to help her go on and off the toilet, and kind of for future planning and ongoing falls prevention. And thank you very much, and best of luck with everything. Thank you.
Lovely. Hello guys, my name is Sinead. I'm a speech language therapist. I'm currently working in the acute medical assessment unit, which is a short stay unit. Our patients come in here from the emergency department, and we try to assess them as quickly as possible, get a plan in place and get them discharged as soon as we can. And I'm also covering the emergency department.
My name's Andrew Keegan. I'm also a speech and language therapist. I work across early supported discharge, which is supporting stroke patients getting home and continuing rehab. And then I also work with medicine of the elderly inpatient as well.
So what is a speech and language therapist? Speech and language therapists are responsible for the assessment, diagnosis and management of various disorders of communication and swallowing. We work with both adults and children across a variety of settings, which we'll touch on. And we work alongside our colleagues who you've already met today, as well as dietitian and medical social worker. This is another video of a gentleman who was admitted to the intensive care unit. From what I can remember is he had a trachea in place, so he wasn't breathing through his nose or his mouth, he was breathing through a tube in his throat. But unfortunately, this patient also had difficulties with his vocal cord, so he wasn't able to voice. So this is our eye gaze technology. What he is doing is scanning the iPad with his eyes and then selecting different icons based on where he's looking. So this is him when he was first introduced to the eye gaze machine.
Dad. I want mum, baby, Dad.
Great. So will you rest for a second?
Family.
Brilliant. So I've met your mom a good few times. I haven't met your dad yet, but I know he's been in. And then is there a baby in the family that... Your babies, as in your children. Yeah.
Perfect. And then
Stroke.
this is him a few weeks later after using the eye gaze machine to communicate for a while.
Hi. Dog. 2. Park. I would like a stroll with my dog to the park.
So as you can see, it can be quite tedious and a little bit difficult to use, and it takes patients a long time to get used to it. But for this patient, it was a really effective way for him to be able to communicate with his family and also staff members here in the hospital.
Perfect. So moving on then, another big area that we work with is people with dysphagia or swallowing difficulties. So in order to swallow safely, we rely on our reflexes as well as our own free will. So if we think about kind of eating or drinking something, it kind of starts in the mouth and then we start to move it back and then it becomes involuntary and then we depend on the muscles and the reflexes in our throat. So swallowing involves 50 pairs of muscles. Muscles must be quick and precise, and we must have good sensations in order to be able to sense the food and the drink. All of this must be present in order for us to ensure a safe and efficient swallow, and then ensure that nothing is aspirated or goes into our lungs, then in turn causing a chest infection. So here on the left, we have what we call a videophorescopy, which is an X-ray of the swallow. So it looks at the movements of the swallow as we eat and drink. So just to, let's go up there. So just to orientate you, so we have the airway here. So what we don't want is food and drink going down that way. We have the epiglottis, which is a little flap that closes over the airway to stop food and drink going down. And then here is the esophagus leading down to the stomach. So I'm just going to press play.
And just what is really dark black there, the blob you can see in the esophagus, that is food that we've given this patient, and we've dyed it with contrast so we can see it.
So as you can see here, there's fluid going into the airway. So the kind of coordination of the muscles required for swallow aren't working properly. So what we would do based off that is we would try the patient on multiple consistencies, see what is the safest for the patient, and then based off their presentation, we would do swallow exercises with the patient in order to improve and try and improve the swallow. So then over on the right-hand side, we have what we call a FEES, which is a fiber optic endoscopic evaluation of the swallow. So it's a camera that essentially goes up the nose and then looks down over the throat into the airway to see whether food and drink is going down into the airway. And just to orientate you, this is the epiglottis. And then this is, I'll actually play it a bit because I can't fully see everything yet.
First has been where?
So there's food and drink being swallowed there. Down here we can see that this leads to the stomach, this passage here, and then you can see a bit better when I play again. Here we have the airway, which is opening and closing here, and above that we have the vocal. So what we can see is that the patient is eating and drinking. So we're kind of checking to see if anything is going down into the airway.
Yeah. So that you're about to do it again? Yeah. Second teaspoon of 0.
Strong too.
Oh yeah. Let's do two cups. I just going to do a little bit more.
So again, just to emphasize, I suppose, the importance of doing these examinations is there's only so much you can tell when you're assessing a patient's swallow at the bedside. So this just gives us more information about how the swallow is and how that, again, could be impacting their overall medical condition.
Lovely. So where can you study speech and language therapy? So there's 3 different undergraduate courses in Ireland, Trinity College, UCD and University of Galway. Alternatively, you can do a master's course, which I know some of our colleagues have touched on before. So there is one master's course in Ireland for speech and language therapy, and that is down in Limerick. And then some other routes you can take to get into speech and language therapy. So you can apply through the UCAS system and go to the UK or to Northern Ireland. Or alternatively, you can do a speech language therapy assisting course to see if you are interested in the job. And there's a range of places that do this across Ireland. For example, so Dundrum, Pearse College, Cavan Institute and Waterford. But I suppose most importantly, seek some advice from your guidance counsellors. They'll be able to discuss with you kind of where is best for you to attend. So what I enjoy most about my job, I love, I suppose, learning how the brain works is a huge part of our job. You learn the brain in detail in college, which is really, really interesting. I love also working as part of the wider MDT team, the multidisciplinary team, as well as working with the doctors and nurses and the patient and the family themselves. And also making a difference in people's lives, as our colleagues have touched on before. But I suppose eating and drinking and talking are, I suppose, 2 big things that we all do every single day and we take for granted, whereas our patients, they often have a lot of difficulties with these areas, and making a difference in their lives improves their quality of life hugely.
Yeah, and I suppose the things that I love about my job as well, so each day is different and brings kind of new challenges and opportunities. And yeah, again, as Sinead was saying, that kind of ability to help a patient improve in their areas of kind of swallow and communication. So I suppose finding out what's meaningful to the patient, what do they value about communication, who do they speak with, and again, kind of making it and tailoring it to something that's actually going to be useful and meaningful for them. So finally, just to touch on the case of Mary. So for Mary, we received a referral that Mary was having difficulty when eating her lunch and that she was coughing when she was eating. So first of all, as part of our assessment, we would do a chart review just to check how she is medically overall and kind of checking for infection markers and how her chest is, because we're keeping an eye on if anything has gone into the chest. So we would then kind of start our assessment. We would check her alertness, her posture, and then we would start screening for communication. So we were speaking earlier about the kind of areas we would assess just around understanding and then actual expression then as well. Would then take a case history, as she's had a recent stroke that predisposed her to a higher risk of having swallowing difficulties. So kind of assessing what she was eating and drinking at home as well in order to inform our assessment. Then as Sinead was saying, just around the brain, that's good. Like we would have learned a lot in college about the brain, and it's very important to kind of understand the anatomy. So we would do what we call an oromotor examination, examining the muscles required for swallow. And then we would assess the patient on various consistencies. So it kind of ranges from kind of thickening fluids, so adding scoops of thickener into the fluids to see if that helps. And then we would also kind of try a variety of consistencies from kind of normal diet kind of down to like kind of puree, kind of spanning that. So based off that assessment, Mary was presenting with an oropharyngeal dysphagia, which is swallowing difficulties of the oral phase and then the pharyngeal phase, characterized by reduced ability to chew the food and manipulate the food backwards, and then she was also coughing when she was eating as a result. So from that bedside assessment, we recommended normal fluids with no thickener, and then a level 5 minced and moist diet, which is similar to kind of, if you think about minced meat, kind of more kind of mashed up food, in order for it to get it back safely. We then listed Mary for a videophroscopy. There's a high risk of silent aspiration, the sensation in the throat being impaired. So we referred her for that. To kind of then ultimately inform our swallow rehabilitation, so we know what areas to target. And then it can be quite scary as well, having a swallowing impairment, and there can be a lot of unknown with it. So we provided education to Mary and her family.
Perfect. Thank you very much.
Thank you.
Are you ready for a break? I'd say you are. So if it's actually 2 o'clock now, so if you want to head outside through the doors you came in, there's some pastries, teas and coffees, and if you want to just get a bit of
Yeah, will I start? Yeah. Okay, hi everyone. Hello. Hi. Yeah, so we might just get started again. So, hello, my name is Magella and I'm one of the dietitians here at St. James's Hospital. I work in the ICU, so the intensive care unit, and I also work in the National Narcolepsy Service here at St. James's. And I've been in the hospital as well since 2018. So what is a dietitian? So a dietitian is a healthcare professional who is an expert in nutrition and the human diet. They have a university degree specialising in nutrition and dietetics, and they've completed a period of training in a hospital and a community setting. A dietitian is someone who applies the science of nutrition to promote health, treat and prevent malnutrition, provide dietary advice to support health and manage illness, and support rehab and recovery. And dietitians are the only nutrition professionals who can work in like a hospital or a HSC community setting. So a dietitian is a protected term, so not everyone can call themselves a dietitian. And we are registered with CORU, which is our regulatory body. So what does a hospital dietitian do? So we diagnose and treat malnutrition. So malnutrition, it was when someone maybe cannot eat enough food and as a result they start losing weight. Or maybe the person is able to eat food, but what's happening is they're not able to digest it properly or they're not able to absorb it. And as a result, they start losing weight. We can start patients on oral nutritional supplement drinks. So these are like high energy, high protein drinks, and these can help support patients who maybe aren't able to eat and drink enough food, so we support them with these drinks. We'll educate patients, especially those who are malnourished, on a high energy, high protein diet, so to make sure they're getting in enough protein for their muscles, and that's especially important as well when they're working with the physiotherapist. We will educate on the modified consistency diet. So our speech and language therapist colleagues will assess and they'll determine what diet the patient will go on, and then we will educate them on this to make sure they're getting enough energy, protein and their vitamin and minerals in. Also, patients could be diagnosed by the doctors with a specific condition, such as celiac disease, and they'll need to be educated on something like the gluten-free diet. So we are also the experts that will educate patients on this. Some people may not be able to eat and drink, and as a result they need to be fed through tubes. So there can be feeding tubes either through the nose or through the stomach. And it is the dietitian who is the expert that works out exactly how much energy, protein, vitamins and minerals that they need, and we prescribe that then. And if a person cannot eat, drink, or maybe their gut is not working, or their stomach, we can then work out how to feed them through a drip. So it's called parenteral nutrition. And this is a bag of fluids, and again, this has all our vitamins, our minerals, our energy, and our protein. And it is the dietitian that calculates up using like math formulas to work out how much the patient needs. So where do dietitians work? So we work in a variety of areas. So like I said, I work in a hospital, and I work in the critical care unit here. Dietitians can also work in nursing homes, so helping older adults to age healthily through nutrition. A dietitian could also work in a private practice. They could work in an area of their interest, and they can have people coming in to be educated in a variety of different areas. Can also work with sports teams and athletes, so to enhance and improve performance. We can work in the media, so dietitians can work in like social media, or they might work on like mainstream media, again educating the public, and these may be dietitians who are working for themselves in the private practice. Dietitians can also work in academia, so in universities. They may work as lecturers or they may do research, so working out what the next dietetic or nutrition trend is or what we should be eating and drinking to improve our health. And dietitians might also work in like the food industry or pharmaceutical industry, so working on the development of new food products or new oral nutritional supplement drinks that I showed you earlier. So what's a typical day in the life of a hospital dietitian? It can really vary from like the hospital that you work in, or again, like the speciality that you work in. So for example, do you work in the ICU or with stroke patients, or do you work in like the general wards? So here in St. James's, we're really lucky. We have a fully electronic system. So in the morning, I would come in and check my emails, and I would also check the patient list. So I would log into our electronic record system, and I would check what patients are on my list for the day. And I would also check for new referrals. So any of my colleagues here can put in a new referral for the dietitian for a patient to be seen, or the nurses or the doctors. So then I would work out, who do I need to see today? What is the priority? And I would go and see the most urgent patient first. So then we would go up and see the patients on the ward. So we would look at the medical chart, and this is our online system. I would look at the patient bloods, what medications they're on, and what the other doctors, nurses or healthcare professionals have recommended. And then I would educate and implement the nutrition care plan then with the patients on the ward. And you can see here, this is Niamh, one of our colleagues here, and she is replacing a feeding tube within a patient. So that's a feeding tube going into the stomach. And we also have another dietitian here, Kieran, and he's checking the hand grip strength of a patient. So that can be useful to monitor, not just along with weight, but how people are responding to the nutrition that we're giving them. As everyone has said here, we'll all attend multidisciplinary team meetings. So these are meetings where the doctors, the nurses, and we will all go to, and we'll discuss individual patient cases, and we'll work together to give the best care plan for these patients while they're in hospital, and try to get them home or to whatever discharge destination they're going to go to. We'll also do education sessions. So as a dietitian, I'll do education sessions like these within the hospital setting, or to my colleagues, or to patients on the ward. So that's a really important aspect of our job. And we'll also do like research. This can be simply just like reading a new research paper to see what are the upcoming trends for like nutrition and the critical care unit, the ICU for myself. And it can be working on research projects to try and improve like audits. So checking, are we doing what we should be doing? So are we following the standard practice that's expected? And if we're not, how can we improve what we do to, have the best patient care here for our patients? And then at the end of the day, I'll type up my patient notes, and I'll also have done that throughout the day as well. And I'll finish up. So in order for like the hospital dietitian to get through their day, like what are their knowledge and skill base? So knowledge, we've got quite a strong knowledge around biology, medicine, we're working in an acute area, and as well therapy and counselling. Like all the professions here today, we're talking to patients, we're listening to their concerns, and we're educating patients. And that's why it's so important that we all work together. What are our skills? We're active listening, so we're good listeners. We'll actively listen to what people are saying. We'll reflect that back to them. And we're also good critical thinkers. We'll think as we work along the job and work out how we can help this patient and how we can optimise their nutrition. We'll also have good skills such as like judgment and decision making, and also social perceptiveness. So putting all those skills and knowledge into our day-to-day practice. And how to become a dietitian. So there are undergraduate routes. So there is the BSc in Human Nutrition and Dietetics. So this is in Trinity College and TU Dublin. So 4 years full-time. And the CEO points range in 2025 was 533 to 601. And you do require at least a H4 in chemistry. So that's important. And this would have been the route that I took. And then there's also a BSc in Dietetics in Ulster University. So this is 4 years, it's full-time, and you need 5 grades at H3 to include at least 2 subjects from math, chemistry, biology, physics and home economics. There are also master's routes, so these include University College Dublin, University of Limerick, University College Cork and Ulster University. So this is if you've completed an undergraduate degree, so you've completed your first degree in university, then you could go on to do a master's. So this is a second degree in university. And these range between like 20 months to 2 years. They're full-time and they all have different course entry requirements. So I would recommend going onto the website and discussing with your guidance counsellor. And the important thing is all these courses are approved qualifications by CORU. So that means at the end of finishing these courses, you can then apply to CORU, which is our regulatory body, meaning that you can work as a dietitian in Ireland. And I've just expanded out one of the courses, the UCD course, because we're based in Dublin here in St. James's. So if we just look at this master's route, what is the example of an entry requirement? And I'd recommend for more detail, please go onto the website of all the master's and undergraduate courses. But an applicant should hold a second class honours degree, such as a 2-1 or a 2-2 in exceptional circumstances. So that's where you have like prior clinical experience, or higher in like a science degree. So this would be maybe biology, food science, human nutrition. Or in a health science degree, such as like medicine, nursing, or another health and social care profession that we have today, or a degree in sports performance science. And these prior qualifications should include evidence of study of human biochemistry and physiology or other relevant degree disciplines from a recognised university. So the important thing for any of the university courses is to look at their website and to discuss with your guidance counsellor. And for school subjects, you'll see for the undergraduate course in Trinity College Dublin and TU Dublin, you required chemistry. You'll see from our knowledge base, biology is very important. And if you've got an interest in biology, I think you'll have an interest in doing nutrition and dietetics. And then home economics as well. This is something I did. That covers a nutrition element as well. So that might be of interest if you were to do this course. And what I enjoy about my job, like everyone said here, it's really rewarding to see patients come in unwell to begin with and then making their way home or making their way to another area and getting well again. It's really varied. No day is the same in here. You definitely wouldn't be bored, and it's a nice challenge learning something new all the time. And nutrition is a science, so it's always evolving and there's always something to learn. And it's great to work as part of a team, like the team of colleagues here, and including like the nurses and the doctors and everyone else from like the catering assistants in the hospital. We all work together to help our patients. And we also work with a great team of dietitians as well. So that makes it a great place to work, and that's why I enjoy my job. And I'm also going to discuss the patient case Mary. And just to recap on the background, like was said earlier, she's a 72-year-old woman living alone. She was admitted after a fall and was diagnosed with a hip fracture and moderate malnutrition. And she had swallowing difficulties after a recent stroke, and she lives alone and has limited family support. So what did the dietitian do? So firstly, our speech and language colleagues placed her on a level 5 minced and mice diet. So I educated her on that from the perspective of making sure she get in enough energy, get in enough protein, vitamins and minerals. And also educated her on how she would make up those meals. So that's really important. And as you can see here on the right hand side as well, we would give patients diet sheets going home. So explaining that. I also started her on oral nutritional supplement drinks twice a day. So this was my concern that on her modified diet, she wouldn't be able to get enough energy or protein in. So this would help with preventing weight loss and will support her rehab and recovery, especially on leaving the hospital. I will check with the medical social worker if Mary can get Meals on Wheels at home. So because she's living alone as limited family support, I'm concerned that she might not be able to make meals for herself every day, and she could do with additional supports. and I will refer her on to community dietitian on discharge from hospital. So what they'll do is they'll monitor to see how well she's getting on her new diet, and they'll also check to see does she need to continue with her nutritional supplement drinks, is she able to maintain her weight, or maybe if she's losing further weight, do they need to increase these or need to give her more advice on how she can optimise her intake. So yeah, thank you everyone. Hi everyone, my name is Ailish and this is Lisa, and I suppose we wanted to talk to you guys today a little bit about social work, and both social work here in the hospital but social work as a profession in general. I know we're the last speaker of the day, so we won't keep you guys too long. So I suppose just to start off, social work, we wanted to include this slide because I suppose sometimes when you tell people you're a social worker, it can be met with a lot of confusion. There's, I suppose, different stereotypes into things that we do, or I suppose misconceptions around our role. So I suppose sometimes the media can portray us as the bad guys, taking children away from families, or that we have a magic wand and we can, I suppose, make these amazing changes happen to people. And look, hopefully we do some good work, but I suppose they are the stereotypes out there, and I suppose we wanted to kind of clear up today what exactly we do on a day-to-day basis. So I suppose in summary, the role of medical social work here in the hospital is to help patients and their families to manage difficulties they are experiencing as part of being unwell. So I suppose in St. James's here, the work that we do is very varied. It can depend on what ward you're working on and what team you're working on. But I suppose to give some examples of the type of work we do, we help patients and their families in regards to some social welfare queries or kind of financial concerns. We help patients and families around planning discharges, so we organise a lot of family meetings. So if a person came into hospital and they were really unwell, and I suppose then when they were leaving hospital, their family might be concerned about how they'd manage, we would often call a meeting with our colleagues and with the medical teams, I suppose, to look at a plan in terms of what's going to happen next for the patient. We organise a lot of supports for patients at home. This can look at a range of different things. I suppose it can include carers, so something called a home care package. So we'll be getting people in to patients when they go home to help them with their personal care. So that can be looking at washing, dressing, things like that. We also help with organising meals on wheels for patients. So some people, they can be really vulnerable and they might just need someone to come in once a day with a nice hot meal, and it can be really important for people. We link patients in with day centre supports. So a lot of patients that come into St. James's Hospital, they might have limited family and friends to help them when they go home. They might live alone, and I suppose for some people they just want to meet up with someone maybe once a week. So to kind of help with those connections, that's really important for people. One big thing that we do a lot of work on here from the social work department is organising long-term care for patients. So that's organising for someone to go to a nursing home. So sometimes people can come into the hospital and they were really struggling to manage at home. So I suppose we work with our colleagues to try get people home as much as possible. But sometimes people can find that really hard. So the best thing for some people might be to find somewhere where they have lots of help and support that they can't get at home. A lot of patients who come into the hospital, they can receive really difficult diagnoses. So one thing that we do a lot of work on is counselling and kind of providing that emotional support to patients. And we work with a lot of patients who might struggle with homelessness. So we kind of work on organising emergency accommodation for those people. So just to kind of tie in with what I spoke about there earlier, we do a lot of risk assessment in the social work department, and I suppose these images kind of highlight some of the work we do on a day-to-day basis.
one really important thing that we do in social work is safeguarding. So we have, I suppose, a responsibility when it comes to patient safety and making sure, I suppose, more vulnerable people are protected from kind of concerns at home, also concerns in relation to children. So we work in, I suppose, a lot of those areas, making sure that people are kept safe, both at home and in the hospital. So, like my colleagues were speaking earlier, who can benefit from our support? And I suppose social work is not just tied down to one cohort of people. We work with people across all ages, and even in the hospital here, while we are, I suppose we work with adults. Just to give one particular example, we have a HOPE team, and they work with, they have a CLIMB program which works with children who have family members who have been recently diagnosed with cancer. So they do lots of work kind of around counselling and support to these children. And then I suppose our work goes all the way up to people in the older cohort, looking at supports and maybe nursing home care. So it's not just, I suppose, one person in particular. We work with a range of different people. And I know I've kind of been speaking a lot about social work in the hospital, but I suppose just to highlight, one of the really good things about social work is that we don't just work in medical settings, but we can work across a range of different places. So just to give some examples here, as I said, we work here at the hospital, but social workers can work in addiction services, in probation services, homeless services, primary care, intellectual disability services, schools, and TUSLA. So I actually worked in TUSLA myself for a few years before I came to St. James's, and it was obviously very challenging work, but very rewarding. So if I suppose you prefer working with children and families, that might be something that you might prefer to try. But I suppose the great thing is that I suppose I started off there, but I realised I'd like to kind of get some experience working within a multidisciplinary team and working in a hospital setting. So I'm just going to pass you over to Lisa, and she's going to talk to you a little bit about skills and interests.
Hi, so some of the skills and interests you may have, be curious about people, like chatting to people, meeting new people, and assessment skills like the rest of the MDT team, communication skills, mediation and conflict resolution. As Ailish said, we work with not just the patient, the families as well, and maybe sometimes our role is to advocate for the patients, and maybe the family wants something different to the patient. Everything comes from a place of love, and there might be a lot of fear around, so it's just making sure that the patient's voice is heard, and just having that chat with the patient and the family together in a safe space. Planning, organising, teamwork and time management. Make a difference in people's lives, so lobby and advocating, and an interest in social care and justice. So you have this social works for you. So the feedback from last year was, what was the difference between social work and social care work? So I suppose the role and responsibilities of a social worker is, social workers often handle case management, such as child protection, court orders, and arranging care packages. So there's less direct work and more office-based work, and social care work that provides a more direct support and delivers those care packages in environments like residential care, disability services, or community settings. It's more on the ground work where you're working with the person themselves, enabling people to live day to day, helping them with their personal care, cooking skills, a lot of inclusion work, like supporting them in employment within the community. And then for education, for social work, a social worker typically requires a higher level education, like level 8 bachelor's degree. Social care requires level 7, both are core with registration. Social work then are often responsible for statutory duties and legal actions, particularly in child protection and family services, and in the hospital as well. Like if there was concerns amongst the team, maybe they'll call the social worker if there's child protection concerns. And social care work, there's less statutory responsibilities. Both start, well, social work starts at a higher starting salary, but increases yearly, and social care work starts with a lower salary but also increases yearly. And I suppose what we enjoy about our job is meeting people. Like, you get to meet all people from like all different backgrounds, working with the MDT team. And also it's a real privilege, as everybody said, but if you meet someone in a hospital, and especially for a social worker in whatever setting you are, they're not in a great place in your life, so it is a privilege to be there and to offer that support for a person, and advocating for a person as well. What I enjoy about my job is no day is the same. I get to meet lots of different people. Every day I learn something new, every single day. I love working part of the team as well, and even when we have those multidisciplinary meetings, like just hearing what my colleagues, their role is, and seeing it all come together, it's fantastic. And just seeing the impact that has on a patient, it's a privilege. The patient, back to Mary. So just the social work input for Mary, the case study. So the social worker looking after Mary in St. James's Hospital organised for Mary to get help from the carers at home. These carers now visit Mary every day and help her with the little things like managing her medication and having a shower. Mary now gets her dinner delivered to her house every day through Meals on Wheels service, as recommended by the dietitian. As Mary lives alone with limited support from family, the social worker also organised for her to be visited once a week by a befriending service called Alone. Mary looks forward to these visits every week, where she has a cup of tea and a chat with her allocated volunteer. Extra supports like this will hopefully support Mary's recovery at home and help prevent her from having another fall and admission to hospital. And how to become a social worker. I only became a social worker last year, so it took me a while to get there. I left school and went travelling for a few years, so I did my undergrad as a mature student many years ago in social care, and I worked in residential services for people with disabilities for 20 odd years, and then I loved my time there, and then I did another undergrad in psychology, and then I did the master's in Trinity. But there's so many different ways to get in, like there's PLC courses, the undergraduate degrees in Trinity, UCC. The master's is in Trinity now, UCD, Maynooth and Sligo, and there's the social work apprentice programs, and that's based in UCC. I think that's sponsored by TUSLA, but there's lots of ways. And I'd also recommend, if you wanted, like if you had a passion for helping people, volunteering, because even if you had an hour a week, it just gives you a good insight into if it's for you or not. Like, so I volunteered along the befriending service that Mary used, and I loved that one, Michaela. So it just gives you an idea of what we do.
I might just tie back in there. I suppose, like Lisa was saying, it's a really rewarding profession. I've been working here in St. James's for the last 3 years, and I suppose I've had the opportunity to work across lots of different departments. I would have started off in general medicine, and then moved into an area called trauma. So I worked with a lot of people who I suppose may have been homeless, who might have had a lot of accidents or traumatic events in their lives. I also worked on the burns unit, working with people who might have had fires in their homes, or I suppose burn victims, and I'm currently working in the area, I suppose, of medicine for the elderly. So I suppose there's such a wide range of opportunity to grow and learn, and I suppose especially in St. James's Hospital, the amount of training opportunities and growth potential that they offer is fantastic. So I definitely think it's a
got them on now, yeah. You just have to speak into this and just pass it around and make sure that whoever's speaking is actually speaking into it. Yeah, exactly. Great. Brilliant. So if you see any hands up, perfect. So, does anyone have any questions? Any hands up? Anyone going to be brave and go for the first question? So I have some here that some people had written down during the break. There's one. Great. Sorry, I couldn't see it.
John, what type of placement did you do on your, in what type of areas, and what was your favourite?
Can you hear me? Yeah. Good question. So in UL we have 4 different types of placements. I know some of the guys in Trinity and UCD would have had maybe 5 or 6 types of placements, but I had 4 placements in UL, which ranged from about 7 to 8 weeks in each. So my first placement was in Portiuncula Hospital, which is just up the road from Athlone in Ballinasloe. So there I was in what would have been called the MSK, the multiple musculoskeletal outpatients department. So I would have been dealing with patients coming into the hospital, basically post-surgery patients, patients with knee replacements, hip replacements, wrist fractures, so generally bones and bruises. The second placement then I moved up the road into Galway University Hospital, where I was part of the care of the elderly team. So that was generally working with patients who had presented after a fall, and patients with sort of neurological conditions like Parkinson's, multiple sclerosis. So that was kind of on the acute wards of Galway University Hospital, so I spent 7 weeks there. And then in my final year, I had 2 more placements. So my third one was what's called ICPOP. So it's actually a community service. So it's the Integrated Care Programme for the older persons down in Ennis in County Clare. So that was basically patients who had been referred out to us by consultants and GPs because they were having frequent falls. That was kind of working with them out in the community on their balance and their sort of lower limb strength. And then my last placement was back in Portiuncula, where I worked in ICU, so the intensive care unit, and on the respiratory ward, so patients who had respiratory conditions and sort of chest infection, pneumonias, and that side of physiotherapy. So I got a good sort of all-round part of it through my 4 placements. My favourite one was actually my last one in the ICU in Portiuncula. So that was obviously dealing with patients who've been sort of a lot more intensive, who need a lot more intensive care. So that was kind of dealing with patients who are maybe on a ventilator, patients who have really acute, so really early days post-operatively. And that actually is in the rotation that I'm in at the minute. So at the minute I'm working in a split between ICU and on one of the respiratory wards here in James's. So yeah, that was my favourite one. Sorry, that was long story short.
Thanks, John. Any other questions from the audience here? Yeah, that lady.
That's would be your kind of area. What the way that you go to that?
Well, it's the same. You do your undergraduate degree and you'll also get placement opportunities in your undergraduate to work in paediatrics. So like I had a paediatric placement as well. During my undergrad it was in a private setting. And like same as that, when you qualify, like you're qualified to work in paediatric settings. So if there are any opportunities, whether that's through the HSE or through private or paediatric OT, you can just apply to them the same way that you'd apply to like in acute hospital or settings like that. So you're qualified to go into them from your undergrad, and you have that experience as well through your placements. No, you don't. So like immediately for us, when you come out of college, you're qualified to go into paediatric settings. So you can start off like on a base grade level and yeah, interview and go into those areas. I can pass over to
So most of my placements in college were actually in paediatrics, so apart from one. So my first placement was with adults in the primary care centre, then I went into the primary care centre with children, and then I worked in the National Rehabilitation Hospital, and that was actually on the paediatric ward there, and then I went and worked in CAMS in the day hospital, also again with children. So I just had a preference for working with adults, so I went into the hospital. However, a lot of my fellow students in college would have gone into working in jobs with children.
Any other questions from the audience? Or I can take, oh yeah, man at the back.
That's a very good question. I suppose it can be particularly in a hospital, it is very busy. Like we were all saying, no 2 days are the same, but majority of our days would be very busy or working on the wards with patients. It can be, I suppose, very frustrating, particularly for patients if you have a rehab goal or something, but there's barriers in the way for them to not achieve it. Or if our MDT want to have the goal of discharging home, but the family aren't in agreement with that. So yeah, there's a lot of frustrations, but with any job there is frustrations. Anyone else want to speak to that? Yeah.
Yeah, I guess, staffing levels at times can make things challenging, and you're often kind of working on a priority basis with patients. So like, as you were saying earlier, you're looking at your list of the patients you need to see, and you're kind of basing it off of who's most urgent for that day. So sometimes that can be frustrating because you'd love to, give your time to everyone who needs it on that specific day, but that's not always realistic, so that can be frustrating at times as well.
My manager is sitting in front of me, so I actually really love my job. I have no frustrations about it now.
I suppose for social workers, I would imagine community resources in the community, like linking people in. There's not many resources, they're limited now, so that can be really challenging.
Magella, you're the only person who hasn't said anything, and I manage Magella, so. Any other questions from the audience? So there's one here that someone had written down, and this is, I would imagine, to all of you. If you're squeamish, would you struggle working in a hospital setting?
So I'm extremely squeamish. That video nearly killed me, but I don't see that on a day-to-day basis, so it's okay, so I don't see those things.
Yeah, I guess it basically, that question sort of is layered a little bit. Depending on the type of work you do in the hospital will depend on how graphic, for want of a better word, stuff you see on a day-to-day basis. And again, even in physiotherapy, in places like outpatients, so people coming into the hospital, you won't maybe see things that'll make you squeamish and stuff, some of the stuff you'd see on the ward or an ICU. So it's very dependent on whereabouts you are based in the hospital. I'm sure from, we see all types of things on a day-to-day basis. So, but I guess it kind of depends on where you are in the hospital, yeah. Yeah, pretty much.
Okay, thank you. Any other questions? Oh, a couple online, okay. Yeah.
What's the starting salary for physiotherapy? Physiotherapists just graduated.
Yeah, I think it's very similar to what was in the board earlier, just from social work. I think around the 45,000 mark, and then depending on how many years you spend in the HSC and what grade you're working at, so whether a staff grade, senior level, that'll kind of increase incrementally, but I think it's around the 45,000 mark from a starting salary point of view.
Okay. What route would you take into occupational therapy?
So for myself, I did an undergraduate, so I went to University College Cork. I think the points were a little bit lower back then when I went in, but I know people do go through the UK route as well, like we mentioned, the UCAS, And often that does go after leaving cert results as well, but I do think they kind of do it on an interview process, but I definitely recommend looking into that. And then, like, as we said, there's, you know, people can do alternative undergrads and go in through a master's route, or else kind of mature student as well. So like those are other options. But for myself, I went into the undergraduate route.
Okay, the last one then, did you complete the HPAC as a speech and language therapist?
I didn't complete the HPAC, but I know for the masters in UL, I think the HPAC can be a requirement to get in, but it's marked differently. I think anyway, it's marked differently than like medical students. You're not, because I know they are required to do the HPAC, but they kind of mark it on a different way or different pathway. But I'd recommend looking into that as well. Obviously, I didn't do that route.
I think it's the same for speech language therapy. For undergraduate, you don't do the HPAT, but my colleague Andrew has nodded at me for the Masters in Limerick, you do have to do the HPAT.
And actually, I'm going to come in on that because I didn't do a traditional route at all. So I'm qualified probably about 15 years or so, and I would check what I'm saying because obviously courses change and access routes change. But there was a course called Health Science and Physiology, and that was in Carlow, and it was also in Sligo, I believe. The course that I did was a higher certificate. It was around 430 points at the time. It was a really good course from a perspective of, I wasn't really sure. I knew I wanted to do something in healthcare, but I didn't know what. So from that course, it was 2 years in Carlow, and you could go into physio. Most of my year that year did go into physio. I went into nutrition and dietetics. Some people went into OT. So it was a really good course to do. And then I did go to the UK, so I applied through UCAS and went to Coventry University for 4 years. So, you know, as the guys have said, and that was 15 years ago, so there's so many other ways now. So definitely link in with your career guidance counsellors. And I think, I'm just looking at the time here, we're on 3:01, and I'm conscious the room is warm. So we're around if anyone does want to talk to us after, but we might wrap up. Just again, please do ensure if you have 2 minutes even just to do that survey. And thank you so much for attending. We really appreciate you coming.